Good afternoon, everyone. Thank you so much for joining us here today on this Health for a Change webinar on this Friday afternoon. My name is Rochelle Seeger. I'm with the Foundation for a Healthy Kentucky. And the Foundation's mission is to address the unmet health needs of Kentuckians. We do that by developing and influencing policy, improving access to care, reducing health risks and disparities, promoting health equity. The Foundation's values are integrity, respect, effectiveness, leadership, policy equity, and collaboration. Today's event is part of the Foundation's Health for a Change training series. This series was begun in 2011, and we've worked with a wide variety of Kentucky community partners. Today's webinar is being recorded. You can find past Health for a Change events archived on the Foundation's website. This afternoon, the PDF of the presenter's slides and a recording will be posted there at healthy-ky.org, Events tab, Health for a Change. Again, my name is Rochelle Seeger. I'm honored to be working at the Foundation since 2013 as a Community Health Research Officer. And today's event is part of Shifting the Lens, COVID-19 and health equity. Today we'll be receiving views from Eastern Kentucky. And this presentation is proudly co-presented with Kentucky Medical Association and University of Kentucky Department for Public Health. We thank them for joining us on this event today. I want to acknowledge before I hand it over to our first presenters that, as we all know, Eastern Kentucky has been hit by the devastating flooding. So I know this has impacted all of us there, and I wanted to acknowledge the challenges that has impacted on our presenters and their work today. First up, we have Samantha Bowman. Samantha is a certified community health worker with Kentucky Home Place. And because of the impacts of the flooding there, she is joining us live here today, but she's also pre-recorded the video for us so that we can hear that clearly, and I'll present that to you now.
Samantha Bowman, and I am a certified community health worker with Kentucky Home Place. I currently serve Lee and Owsley counties. We always like to mention funding for our program is a joint collaboration of the Kentucky Cabinet for Health and Family Services and the University of Kentucky and the Center of Excellence in Rural Health. On behalf of Kentucky Home Place and myself, we would like to thank the Foundation for a Healthy Kentucky for asking us to discuss our experience with COVID-19 while working with clients, the impact it has had, changes we've had to make, and additional services that we've offered during the pandemic. Here's a look at some of our current CHWs with other staff members. At least 2 CHWs have over 20 years experience working with Kentucky Home Place. The map shown here is our current service area. Currently, we have 23 community health workers that serve 30 counties in Kentucky. Some of our CHWs cover more than one county. Each CHW has their own specialty, and the lines of communications between each CHW is always open. We help each other almost daily with resources that might be available in different parts of the state to help one client. Like many, the COVID-19 pandemic has shined a light on many of the challenges that we have all faced over the last year. So much was unknown about this virus in the beginning. As many, we had a very short notice that we would be working remotely beginning March 17th, 2020. We worked quickly to set up off-site offices. We had to change our contact information and had to work with one another to see what was the best route to make sure that our clients could get in contact with us as quickly as possible. Connections in the virtual world, such as Zoom, WriteFax, Skype, text, social media were all huge platforms that we used and was a great asset on a daily basis. We began having weekly staff meetings instead of once monthly, and we produced weekly reports. Also, many of our CHWs have families, so we were at home, most of us working with the challenges of switching everything to virtual, including schools and home life. When working remotely, each of us have our own fears, but ultimately we all had one ultimate goal in mind. And we began to focus on new service areas that were now available to us. We had to challenge our current policies and procedures. What used to have to always be done in person was now able to be done with a verbal consent or able to mail. We were able to attend community meetings and agency meetings online. And then we began to present home place virtually. Some of the new services that we were able to offer was assisting our clients with 2020 census. Many of our clients simply did not understand how to complete this process, and they wanted to make sure that they were counted. So we worked with each individual to make sure that they were able to complete that process. Presumptive eligibility Medicaid was statewide and still ongoing. Many individuals that would have never qualified for Medicaid in the past was now able to qualify because the income was being relaxed and the guidelines were being relaxed. So a lot of our clients were able to receive life-saving procedures along with preventative services. We were able to help with the pandemic economic benefit transfer, which is pandemic food stamps. And this was for all Kentucky residents that their children go to a public school, regardless of income. So we were able to help a multitude of people get that benefit. Then we was able to help with economic impact payments. If you had never filed a tax return, then this was an additional step that you had to do in order to get that payment. Many individuals had no idea, did not even own a computer, could not complete that step. So we were able to help them with that. Insurance providers were offering meal plans. Certain insurance providers were offering meal plans up to 14 meals per individual. So we were able to help several receive those. In the beginning of the pandemic, you couldn't even find hand soap or hand sanitizer, much less a mask. So we would have elderly people contact us and say, I have a doctor's appointment, I have no mask, or I need to go into the store and I have no mask. So we would get them one. Several would do home visits and leave them in their mailbox or mail them their face mask or gloves or whatever it was that they were requesting. Biggest thing we did was educate individuals on COVID-19 because there was so many people confused about it, and do you social distance with your, people outside your family, a lot of misinformation. So we gave them concrete CDC guidelines on preventing COVID-19. We were able to reach out to MCOs and give out cell phones, especially for those that are needing them for telehealth visits. And then we were also able to educate them on how to use those cell phones and download the apps so that they could use telehealth. At the beginning of the pandemic, if you remember, there was a limited amount of testing sites where you could go and actually be tested for COVID-19. So we would have individuals reaching out to us and saying, I'm sick, I was around such and such, where do I need to go to get tested? And we would work with the provider, the health department, in order to find them the closest testing site available to them. The next is the COVID-19 vaccine appointments. This is still ongoing. Many of our elderly patients or clients don't have the access to complete an account through some of the pharmacies that are requesting it. So we can do that for them, and then we can go through and let them know what dates are available along with the appointment times. And that has worked out excellent. I know in my area, a lot of people rely on me to help them set up those appointments. Then scheduling the telehealth appointments. Have several people that had never had one, didn't even know where to begin. So we would reach out to their healthcare provider or to the VA and get those scheduled for our patients. Next is the absentee request forms. Most had no idea how to even start the process to request those. And it was something that most of our clients wanted to take a part in. They did not want to miss the opportunity to have their votes counted. So we helped them. We helped them request those absentees that was mailed directly to their homes. Unemployment assistance. We've all heard for the last year the stress and worries that many citizens of Kentucky have had regarding their unemployment claims. Thankfully, some of the CHWs have helped individuals get their case resolved and the payments coming in. The next is something that's near and dear to my heart. It is we've been able to reach out to those recently regarding the flood relief. Both of my counties that I cover, Lee and Owsley County, was completely devastated by the floods. We've been able to help with resources for applying for emergency grant money, food, shelter, cleaning supplies, cases of water, diapers, even hay for our farmers. We've been able to get those resources to the ones that need them right now. Self-Management Resource Center. We've been doing a toolkit workshop. This is where we have 6 classes, and each classes can have up to 5 or 6 patients or clients that want to go through the workshop. And it's something that the clients have really, they missed it. You know, some of them have came to other classes that we've offered, but being able to be involved with that right now and has really been wonderful for our clients. This here, it shows you, if you remember the map from the beginning of my presentation, you can see that more blue is being filled in. That's because since March 17th of 2020, we've been able to go out past our county lines and help individuals across the state of Kentucky, whether it was for the pandemic Medicaid, for Census, or the economic impact payment, for meals, for telehealth. And you can see there the clients that have received those services during the last year when they needed it the most. And then my last slide here is just a picture of my current office in Lee County. That was on March the 1st. Again, completely destroyed our town. Never thought I would ever see a boat going down in front of my office there, but indeed it happened. And then same with Johnson County, right there where the arrow is, that is Judy Bailey, a current CHW. That's her window. So got a lot of rebuilding to do here in these counties. And I'd like to thank you for listening to us today. And if you have any questions, please let me know. Thank you.
Thanks so much. And next up in our presentation is Dr. Maria Brayman, from Chief Medical Officer at Appalachian Regional Healthcare. Welcome.
Thank you so much. And I want to thank you for having me here today. I'm going to tell you, I seem to be having a problem getting the share my screen again. So if you wouldn't mind just putting the slides up, I'd appreciate it. Thank you so much. So again, thank you for having me, and I'm very excited to talk to you today a little bit about ARH's experience here in Eastern Kentucky. We do span 11 communities in Eastern Kentucky. And we started on this journey, like most of you, in February of last year. And I was looking over my notes prior to coming to this, and it was February 24th that I pulled together the first emergency command meeting. And by the following week, we were meeting daily, oftentimes multiple times a day. And you can go ahead to the first slide, please. We started meeting multiple times a day. By March 1st, we were having leadership conferences at noon every day with the entire leadership team across the ARH system to provide daily updates, because as everyone may remember, at that time, information was changing at times hourly. And in order to keep our staff up to date, we had to at least meet with them daily. And so, and as was mentioned already in Samantha's presentation, getting testing even in the beginning was a real challenge. So I just want to start off by sharing some of the data from, at this point in the ARH system. So now we have tested 137, 422, well, I shouldn't say individuals, but that many tests, because I'm sure there have been some people that have been tested more than once. Really, it was such a benefit once we were able to not only partner with the state, which was very helpful with testing, but we were able to bring in a lot of in-house testing as well. And once that opened up, it was very beneficial to the communities that we serve. Positive tests, ARH as a system has had 8,624 positive tests, and that's an overall 6.3 positivity rate. Right now, we're hovering around 4%. We're pretty close to where the state is across our system, but we have ranged between 2% and 12% positivity. There was a short period of time around the holiday season or post-holiday season where we actually went up to 18% positivity rate. COVID positive inpatients, we have had 2,058 inpatients, and as a system, we have experienced 205 deaths, and that's almost a 10% mortality rate for those patients that ended up in the hospital. We can go ahead to the next slide, please. The other thing that we were very fortunate to be able to partner with the state on, and it was vaccinations. That once the vaccine came, that was really, just our happiest moment in this pandemic, where we thought we finally might have some relief. And Eastern Kentucky is a challenge logistically in terms of being able to get vaccinations out because of our geography. And the state was having a challenge getting vaccine to us, again, because of the logistics of the distance between locations. In the inner city, you might be able to have multiple vaccine locations within a 10 to 15 mile radius. In Eastern Kentucky, our communities are literally over the mountains and through the woods, and it might take 90 minutes to get from one community to another. So we were very fortunate to partner, and we accepted at one of our locations in Hazard all of the vaccine for our entire, that we could then spread out across our 11 communities. And we're very familiar with the logistics of getting to all of those communities. So that was really an important asset for us to be able to share vaccine in all of the communities that we share, that we are in Kentucky. And to date, we have administered 44,273 total vaccines, and greater than 30,000 of those folks are fully vaccinated. We do have the Moderna and the Pfizer vaccine. Both of those require 2 doses. We do not have any of the J&J or single dose vaccine in the ARH system. Next slide, please. Thank you. So lessons learned over the course of this past year. Communication. I cannot say that enough. We started early and often communicating within our system, across our system, and also with our with the public health department and all of the communities we serve, with Dr. Stack and his team, and then with our public officials, both our county execs, our judge execs, our mayors, all of our county officials, we were coordinating with and communicating with early on. PPE, lesson learned on PPE. Prior to the pandemic, we were very committed to what we call just-in-time inventory, and we really didn't stock more than your immediate need for PPE. So that's something that I think many of us moving forward will ensure that we have certainly at least a couple weeks, if not a 30-day or more supply of PPE. We were very fortunate. We planned early, we started conserving, we scoured literally the globe. We never ran into a deficit with PPE. So that was very fortunate. We were able to keep our staff as safe as possible throughout the pandemic. Televisits. Samantha already mentioned that in her presentation. We already knew that telehealth was, the way of the future, and COVID has just catapulted that for all of us, I think, nationally. So televisits, telemedicine, tele-ICU, we utilized all of these. We are really on the fast track now to fully incorporate all of these modes into how we move forward in our delivery of care. We're trying to ensure that we pull together now not only the televisit, but also all the required ancillary services. If there's needed laboratory work, radiology, etc., we're trying to make sure that we're accessing all of those easily in conjunction with the telehealth visit. Teams meetings also, or Teams or Zoom, or all those platforms. Another thing mentioned here, this is again transformed the way we'll do business. Although there's a lot to be said for when we all are able to gather in person, and there are things shared that you can't share as effectively over Team or Zoom. We also now know that we can be very productive working through this platform, and really are going to work to update our facilities more so that we can incorporate both people who can be in the room together as we move forward, as well as bring people in via Teams or Zooms, do a hybrid model. Even our board meetings, we're working on that as well. And working from home, but I think that there was a great fear in our corporation to have people go home, and would they be productive? And quite frankly, I think we found that people are at least as productive, if not more. And sometimes I worry about my staff, making sure that they take some time in between going from Zoom to Zoom to Zoom meetings. So yeah, lessons learned there. Next slide, please. Thank you. So now we're really moving forward into what I call the phase of being our new normal, not going back to exactly where we were before. And our new normal, masking, continues to be part of our lives. Social distancing and smaller crowds. It's nice that the CDC has now opened up for vaccinated people to get together in small groups, or at least 2 families without masks. But again, we need to be very careful that we don't extend that to larger groups, to larger groups. And now, of course, the public health people are here and they can talk more about that. We're reducing visitation, I think, in our new normal in the hospital. you know, it's in Eastern Kentucky, it's part of the culture that, you know, the extended family comes to visit with you in the hospital. And we could easily walk into a room where there were 10 people, 8 or 10 people. That as we start to relax visitation, I don't think we'll get back to that size. It's just not, it's not safe from an infection control standpoint. And so that's going to be part of our new normal as we move forward. I already touched on reimagining the workplace design. I think not only are we talking about more people being able to work from home, but as we redesign our administrative workplace, we're looking at things like, you may have heard the word hoteling, where people don't really have their own desk inside the office, but they can get online, they can register, and they can come in and use that desk for the day if there's a need to be in the bricks and mortar office. Virtual visits, we already talked about, again, are here to stay. I think they're going to be a major part of our future going on, and the consumer, the patient, likes being able to have a virtual visit. So we'll continue to progress in how we deliver that care. We do need to bring our patients back for preventative and routine care. We've had significant reductions year over year in our volume of people coming for things like their colonoscopies and you know, wellness visits and childhood vaccines. So those are things we're really doing a big push on, trying to ensure that people know that it's safe to come back and that we are concerned about people waiting too long to take care of those routine preventive care things that need to be done. And, you know, then we now know how to quickly come together, be prepared, respond quickly, and maintain the safety of our staff in the event that we face anything like this again. And it's quite possible, right? We know that that infectious diseases are global, that people travel globally, and this might not be the last time that we experience something like this. So we're ready to respond more agilely, you know, be a little more agile than we were as this all started this time. So that's thank you very much. I think that's the end of my presentation. So I will go ahead and pass it off to Dr. Bensema.
Thank you, Dr. Brayman. I appreciate that. And I've got to say, working with Dr. Brayman a couple of times now throughout the pandemic, the leadership and grace has just been impressive, and cannot thank you enough for all you do.
Thank you so much, Dr. Bensema, and I appreciate working with your team. It's really been quite special. Thank you.
All right. I'm going to begin to share here. And if you find that some of my data is hidden, if your video images are in the right sidebar, just double click, it will shrink it a little bit, put the video images up on top, and you won't have the last column blocked out. A little trick I've learned. The thing I'm going to do today is present the rural urban classification and then data that reflects this stratification of populations. This is the 2013 urban rural classification rules. They're used federally, and so we've applied them to the state of Kentucky. Once you see the map, it will look pretty familiar to you in terms of the distribution through the state. And what I'll do at the end is we'll do a roll up of the large metros, large fringe metro, medium metro, small metro, and micros, and compare that to the non-core or rural group. So this is the map, and you can see the non-core being the lightest green is solidly Eastern Kentucky. You can see the next level up, the small metro or the micropolitan gets a good portion of the I-75 corridor that we know of, with London and Corbin included. But just about everything that Dr. Brayman and her team take care of is in the non-core. Then you'll see the kind of what I always think of as the old Western Kentucky coalfield area, that rural belt, and then the lakes area, Cumberland and Dale Hollow. And so just orienting you to the areas that get brought out in this. So this is our population distribution. Large central metro, 766,750, and I'm blocked myself. That's not going to help. It's 757. That's Louisville. Louisville's the only large metro classed area for us. Large fringe metro catches Lexington and some of the northern Kentucky area. Medium metros, Richmond, Kentucky, Shelbyville, Elizabethtown, Bowling Green, Warren County, places of those sizes. And then the rural you saw on the map. Case distribution, fairly even. It doesn't, you can't say anything about it because you've got to do it based on population. So we'll get some case rates, but this is the case distribution, and all of the figures and calculations are effective as of March 16th, 2021. We know this is a rapidly changing pandemic. I needed to be able to submit my slides, get the approval at state level, but also submit them for presentation. And so we cut it off at March 16th. I'm very well aware that the governor presented some additional data last night from the audit that we are doing of death cases, and that has increased some of the numbers. And we'll talk about that a little bit more at the end. But as we look at data in this pandemic, we have to recognize that to make hard conclusions from data at this moment in time would be like deciding the outcome of a baseball game during the 7th inning stretch. You still got a couple innings to go. Bottom of the 9th can change everything. And so we just have to be aware, pay attention to the numbers, act on the numbers as they come, but know that they're not the whole story. The whole story of this is going to take years for us to tell. Hospital admissions as of March 16th, you can see the distribution throughout the regions. Again, can't tell anything until I get to case rates. ICU admission numbers as of March 16th. Deaths, now they're starting to get to where people are very curious about. Everyone is hanging on the governor's every word when he announces the death reports each day. And so this shows the distribution of deaths by the areas. Now we get to usable data, because data is only good once you start applying some measures to it that can be normalized. And so this is incidence per 10,000 population in each of our regions. And as you can see, the incidence in the large central metro is statistically significant. I'm not going to go into all the stats of it, but it's statistically significantly higher than in the other areas. And that's been seen across the country. We know the more dense population has a higher rate of spread for a lot of the reasons you would think. It's harder to do social distancing, and the living arrangements are often closer together. You pass people in hallways and elevators, et cetera, more frequently. The rural area came in towards the lower end, also makes some sense. The large fringe metro, Lexington, et cetera, suburban areas, Northern Kentucky, there is some equity issue there that I can't answer. Somebody smarter than me is going to have to, but it's an area to be looked at. But the rural area is probably because spacing is a little bit easier, the density of the population is less, a little more outdoor life. Case hospitalization rates per 10,000 cases. So for each case, or for every 10,000 cases in these different areas, this is the amount of hospitalization that occurred. And you can see the medium metro and the large fringe metro had quite low hospitalization rates. The rural had the intermediate, and then the large central metros had the highest hospitalization rates per 10,000 cases. Again, smarter people than me are going to be parsing this, but this is good starting point to have discussions. Case ICU admission rates, again, very much higher in the large central metro area, and modest in the rural and micropolitan, with significantly lower in large fringe metro, medium metro, So again, is it an access to care? Is it proximity to hospitals? Is it timeliness of care? You know, there are so many variables in this that, again, it starts a conversation and a way of looking at things. Case fatality rates, this is where the differentiation happens and hits the rural area. And I have friends who used to be very involved in the cancer registry for the state of Kentucky, and they would tell you that the numbers basically look like this. In that, the large central metro had 117, and again, this is as of the March 16th numbers, 117.4 deaths per 10,000 cases. But the rural and the large fringe metro and medium metro, again, had lower rates. The rural had a significantly about a 45% higher, or 145% of what the average was. We'll see that again as we do this direct comparison. So now I've rolled up all the other 5 groups against just the non-core rural, just the light green. So again, not to call Dr. Braman out, but Dr. Braman's area is the area that we're focusing on, along with some of the Western Kentucky rural regions and South Central rural. And so you can see cases, hospital admits, ICU admits, and deaths through the regions. Again, it matters on population. So this is how the population breaks out. The non-core rural area of Kentucky has just under 1 million individuals, and the urban micropolitan roll-up has about 3.5 million persons. Direct comparison of urban to rural on incidence. Incidence is pretty close. In fact, non-statistical significance in that difference. Case hospitalization rate, same, very close, not statistically different. Case ICU rate, same, not statistically significant. Case fatality rate, boom, it separates again. Rural has a higher experience of death rate. Again, is it premorbid conditions, burden of disease in advance? Is it delay in care? Is it somebody's going to have to talk about this? But this gives us starting points for having the discussions. Based on what the governor presented last evening, I pulled those numbers. That's like the royal we, right? I have very, very, very good data scientists who are pulling this for me. And the new number with the added in deaths that the governor reported would have the urban roll-up case fatality rate being 110.58. So actually improves a bit. It makes some sense. A lot of these were a little later in these cases as we go on, are later in the pandemic. We have developed some better treatments in general in the hospitals, even though we don't have a silver bullet treatment. We have better ways of treating our patients. We don't ventilate as quickly. We do better respiratory toilet and prone positioning and other things to avoid ventilation. But then the rural one bumps slightly to 160.92. So the disparity increased with the additional numbers. So the take-home numbers are 110 versus 160 for case fatality rate as of this moment in time. And again, this may be the beginning of the 8th inning, but we're still not near the end of the game. And so I just put those as cautions. And sorry, that is my final slide. Again, these slides are going to be available, and if the Foundation for Health of Kentucky will allow me, I will update with the newest numbers, the numbers that I commented on as of today, so that the slides that will be posted for your consumption, your use, and your review will be with data that's effective as of March 19th, 2021. Thank you for this opportunity. I am so grateful for the work of the Foundation, and I am going to pass it on to Dr. Emily Messerly. Thank you. Let me stop sharing. There we go.
Thank you so much. Do you have my slides to pull up for me? That would be great. Thank you very much. So yes, thank you for the invitation from the Foundation for Healthy Kentucky. I am Emily Messerly. I'm the Immunization Branch Manager at the Kentucky Department for Public Health, and I am a practicing still primary care provider in both the pediatric and adult setting. Next slide, please. So I want to go over what the overarching goals are of what we're doing at the State Department for Health, for Public Health, to get the vaccine out to Kentuckians. Our charge from our partners at the CDC is to ensure equitable distribution and administration of COVID-19 vaccines. So we are doing this by monitoring vaccination coverage among population subgroups, identifying populations in geographic areas with low coverage. And then we are both implementing and evaluating certain interventions to make sure that we direct vaccine and the vaccination efforts to increase coverage. These efforts for us will become hopefully easier as we have a third vaccine available and as we have more inventory of vaccine that will become available to us in the coming months. So one of the very important things we do is monitor and improve access to vaccination in communities with a high social vulnerability index. Next slide, please. So this is a very recent report that came out based on an MMWR that was released on Wednesday of this week by the CDC. And what it shows us is and I'll kind of walk you through this, use my pointer a little bit. So as you see, based on the color here, so VR means vaccination rate, SVI is social vulnerability index. And so we see that the darkest burgundy counties have a high social vulnerability index, but they also have a high vaccination rate. And then what we see over here in the bottom right-hand corner, and what I want to comment on is we do know here at the state that we have had reports, and the governor even mentioned on his press conference that there are certain sites around the state, these large throughput sites like Pikeville Medical Center, that have open appointments. So as we see this and as we see areas have softening, so to speak, of where the vaccination has had its reach, we will be working to make sure that we do targeted assessments and shift our vaccine allocation across the state. So in the bottom right-hand corner are counties where you have low vaccination rate, but high social vulnerability index. So low vaccine with a high vulnerability. And so we do see pockets of counties here that do have that. And I will list them by county for your knowledge if you work in any of these areas, so that we know we have more work to do to improve our equitable allocation of vaccination. Next slide, please. So I want to first highlight from this CDC report that we have counties in the eastern part of Kentucky who have a high social vulnerability index. However, they show that they have a high vaccination rate. So Carter, Floyd, Johnson, Knott, Lawrence, Leslie, Letcher, McGoffin, Perry, Pike, and Rowan are, based on the CDC metrics, are doing a good job of getting the vaccine out there and are getting a good saturation. Next slide, please. Some of the counties on this report that show a lower vaccination rate with a high social vulnerability index fall in Bell, Breathitt, Estill, Harlan, Martin, Montgomery, Morgan, and Whitley. So these are areas where working with our partners in our federally qualified healthcare centers and our health departments across the state, these are counties where we will focus and make sure that we have enough sites, that we work on promoting vaccine confidence in those counties. And that's how we can have our targeted outreach. Next slide, please. So the overarching goal of what we at the Kentucky Department of Public Health is increasing equitable access to vaccine. So what we're doing at both the state level and then encouraging local health departments and local healthcare coalitions is to expand on the work of vaccine equity committees or similar committees, ensuring transparency and engagement with the community. Just today, I think by me sharing that map with you, although it is something that is publicly available with the CDC, we are being transparent with where we know there are pockets of low rates of vaccination. So we are working on and do have written plans to how we address these high risk and specific populations and how we reach these groups, including congregate settings, correctional facilities. Our health departments are working to send in strike teams to vaccinate correctional facilities. Our health departments across the state are already working on and have vaccinated homeless populations. Now we come to the big elephant in the room, essential workers. So essential workers is a very large group of individuals. I do want you to know that we are working to reach essential workers who have not yet received the vaccine, and we will be working with partners across the state to partner with occupational health providers to improve access and reduce barriers to getting vaccine by potentially providing vaccine in the workplace, in large congregate workplace settings. Next slide, please. So again, this is actually the chart from the MMWR, and I have the link to it above in the slide. And I want to show you that, so we have high, moderate, and low vulnerability. And this is a chart showing the normalized distribution of vaccination coverage. So based on the vulnerability of the county, where are we getting our vaccine out? So Kentucky is about in the middle of the pack, so to speak. I believe we are 23rd, but if you see the dark navy blue shows what percentage we're reaching of our high vulnerability counties, and then moderate and low. So you can see that if we look at, we're less than 40% in our high vulnerability as far as reach. So we do definitely still have work to go, knowing that to reach herd immunity, we need to have at least 70 to 80% of the population. Next slide, please. So how do we fix the disparity of certain areas with a high social vulnerability index and a low vaccination rate? We need to work to partner and plan activities with critical organizations. Now that we see that Governor Beshear has said by April 12th, everyone 16 and above will be eligible for vaccine, think about all of the organizations that we across the Commonwealth need to partner with now. And what I mean is not partnering with how are we going to get vaccination in their vaccinations in arms, but how are we going to make sure that those individuals make appointments to actually receive the vaccination? So increasing vaccine confidence in not only providers, but in the population across Kentucky is very important. Partnerships with colleges and universities. As I mentioned before, occupational health settings for large employers. Churches and religious institutions are excellent partners, and we have seen these happening already around the Commonwealth. Our federally qualified healthcare centers and community health centers in the United States, federally qualified healthcare centers provide care to 60% of the patients who they provide care to are part of what's considered a vulnerable population, whether it's based on race, ethnicity, socioeconomic status. So engaging with federally qualified healthcare centers, community healthcare centers is critically important. Pharmacies, I think you have seen how the Commonwealth has engaged with pharmacies already across the state. It's known that 93% of everyone in the United States lives within 5 miles of a pharmacy. So utilizing the pharmacy network and footprint across Kentucky has been part of our plan from the beginning. In fact, one of our larger chain partners, Walgreens, was chosen by the federal government to receive federally allocated vaccine because Walgreens specifically has the largest footprint in Kentucky. Long-term care facilities were partnered with early on in the response, where we utilized Walgreens and CVS to do on-site clinics to those long-term care facilities. However, we've done a good job with the residents. There is still work to be done with those staff members in those long-term care facilities. And those staff members do fall into some of the groups that fall into being considered socially vulnerable. So we are working with our partners with OIG, with the HAI at KDPH here, and we are working to make sure that we have a robust education program to make sure that those long-term care facility workers who have not gotten vaccinated get that education and that connection to make an appointment to be vaccinated. Next slide, please. So again, stakeholder engagement is very important. We talked about organizations to partner with. We need to be creative in thinking about non-traditional providers and locations that serve high-risk populations. If you all have seen anything in the news recently, the CDC is in talks currently to partner with Dollar General to improve vaccine. I see Samantha nodding her head. I think it's an excellent idea. I'm not sure, Dollar General has not enrolled with Kentucky to become a vaccination provider, but I'm sure the vision is that they will be a site where perhaps a pharmacy or a clinic would bring vaccination to the Dollar General site. So I'm excited to see that partnership come to fruition. So working with all partners that serve the underserved, schools, now that schools are back open, I am across the state, I am very hopeful that our school settings and our family resource centers will become places that connect with the community to hold vaccination clinics, perhaps in school gyms. There's many opportunities there. Next slide, please. So the last slide here is a list of links that I received recently from our communication division at the CDC. There are talking points, how to speak about COVID vaccine with friends and family members. Although you may be a healthcare worker, not a healthcare worker, how do you talk to people about the COVID vaccine? There's facts and myths, communication resources, what are the benefits? And then the last one there I wanted to touch on because school settings and childcare, the month of March, the CDC has designated as School and Child Care Vaccine Awareness Month. And this link has a tool to help communicate and increase vaccination in the staff within the school and child care program. And I do believe there still is some catch up to do in that area. And I hope that all the partners on this call will utilize this toolkit to do that outreach. Next slide, please. Thank you very much. My email and our KY COVID website are on here. And thank you very much for all that you do to protect Kentuckians against vaccine preventable diseases.
we're very close to the top of the hour. I want to extend my deepest thanks and gratitude to our presenters today for sharing with us their expertise and their time so that all of Kentucky can know this up-to-date information on what we can do to make improvements for all of our state in battling COVID-19. Thank you to all the participants who joined us today. After Dr. Bensema sends his updated slides, those slides from our presenters will be posted to the Foundation for a Healthy Kentucky's website. Thanks to each of you again. It's a deep honor to have you on the call today presenting with us. This concludes today's webinar.